I am going to introduce Ann Turner. I wanted to introduce Ann because she works with us at Vanderbilt Medical Center. She's been with our team now. I think she's going on her 4th year. And like how Pauline mentioned, a lot of nurses that take care of these patients come from the ICU setting and came from the palliative care setting.
Well, and ICU before palliative care.
All right, I'm corrected. So, but what a wonderful place to come from. She's kind of engaged in helping people who are facing things like end of life. But Ann has also got a law degree. And you ever mess with Ann and send her a denial letter for oxygen? One of the best things about Ann's letters that she writes is she lets me sign them. So she'll send this letter, and her red hair gets on fire and her head's spinning around, and I get this letter and I just laugh to myself. So if you ever want to mess with somebody, put a lawyer in a nurse's seat. And so Ann is both of those, and let her go to town for your patients. So Ann Turner.
After that, I'm very excited. I want to reiterate what everybody else said. We're so excited we have a session and that all y'all are here. So thank you. I'm going to talk about doing management of medications. Big, huge subject. I'm not going to try to do medication education with you because that one drug alone would take the whole session. Sorry about that. Accessing medicine. I just did not too long ago, a 30-minute talk just on accessing medicines with specialty pharmacists. So instead what we're going to try to do today is put some practice pointers out there. And hopefully they will be things that y'all will find helpful. So we're going to talk about practice pointers for accessing ILD meds and for managing them. There is, for many of these medicines, there's a large number of people who don't end up, for various reasons, sticking with them and staying on them. So, of course, our goal is ultimately to help our patients be successful. We have a lot to do in that we have to not only look at their specialty meds, but supportive therapies and their comorbidities. So it's a lot on our plate. What I'm going to talk about is I'm going to focus on nintedanib and pirfenidone, the IPF medicines, and as she mentioned, OFEV has now been approved for scleroderma. I'm just beginning to have experience with that, so I have no tips or tricks for that yet. Our center director also is working with me to figure out, he's got a progressive fibrosis diagnosis that we're going to try to get some OFEV for. So this is all new, don't have any experience yet to share with y'all. For the immunosuppressives, there's a whole bunch of them. I'm going to focus on the ones that in a pulmonology office you're most often seeing, and that's the mycophenolates, Cellcept, and Myfortic, which I've just sort of put together, methotrexate, and azathioprine. Other types of immunosuppressives, very often, if a patient is on those, it was prescribed by a rheumatologist and is usually being managed by their clinic. So for patient access, I need to look at that so I don't get confused. For our nursing challenges, we're dealing with expensive specialty drugs. We've got to get them access and on the medicine. They have lengthy side effect profiles. Most of them have complicated titration schedules to follow and have important lab monitoring. So those are the big things that we have to keep in mind. When accessing medicine, my best advice is don't volunteer information to insurance companies. Insurance companies, you have to view them with a very cynical attitude, which nurses don't usually have that attitude, but you've got to be cynical with these insurance companies and assume that they're going to find ways to deny your patients access to care, and just approach it from that point of view. And so, yes, I answer the basic clinical questions, but there's always a little box that says, send everything you've got. And they would love that if we would just send them the chart. We're not going to do that. Now, if they freeze the PA or they deny you, we may have no choice but to send them some documentation. But we can be selective in what we send them. If you've got some wishy-washy HRCT that says, well, that doesn't really look like UIP to me, well, don't send that to them, Just leave it off. Send them the clinic note where they talk about their multidisciplinary, and we came to this conclusion stuff. And so if you've got someone like Wendy was saying, you've got PFTs that look relatively normal, don't send that to them. They're going to use that to go with it. Always, always, always appeal denials. Many companies, especially Blue Cross, will sort of reflexively just deny everything. So go ahead and appeal. For financial assistance, again, this can easily be its own talk. If you do it every day or you do it frequently, try to get these medicines, then it behooves you to learn that process and do it yourself, because it will get your med to your patient quicker. If you do it less often or you don't have a support team in place, that may not be realistic. If that's your situation, then what you can always do, not just with these medicines, but with others as well, is just get on Google and type in whatever the drug name is, patient assistance program. It's going to pop up. It's going to take you to where you can apply for that. Manufacturers want your patient to be on their medicines. They will help you. In the case of Esbriet and OFEV, both Genentech and BI are wanting to do anything they can to help assist you with that process. So if you don't know all the before steps or where to turn next, give them a call, and they can help you out. For the immunosuppressives, we run into the problem of qualifying diagnosis. Technically, most of the immunosuppressives are approved by the FDA for transplant. Some of them are approved for only certain types of transplant. The thing is that we know that for connective tissue, for example, they've been the standard of care for forever. So whenever you have a patient who has a connective tissue diagnosis, forget the lung part, just use that diagnosis. If you don't have anything that resembles that and you're trying to get something through that's going to have a lot less documentation, then state that it meets their off-label criteria by such and such. Now, does it matter that you have no clue what their off-label eligibility criteria is? No, you're not going to know, because insurance companies keep that information a secret. Half the time you don't know what the formulary is, you don't know what the eligibility criteria. So just write with authority that, and it works. If they want documentation, there's plenty of it out there. You can easily send a stack this thick of journal articles, society position statements, all showing that this is standard of care. For financial assistance for the immunosuppressives, it basically works the same way. There's commercial copay cards, there's private foundations, such as Healthwell and PSI Inc., that helps pulmonary fibrosis patients. I was not able to find a manufacturer PAP program for azathioprine. I checked right beforehand to make sure nothing had changed, and there doesn't seem to be anything available for azathioprine. The good news is that these medications are generally far, far less expensive, and they usually have a good RX coupon available. In fact, it's not uncommon that I find my patients are financially better off using good RX than using their insurance. So, key considerations when you're managing these patients. One is, I know it can seem rather obvious, but really listening to your patient and having those conversations to help you identify barriers and how can you work together to address it. I think that's the single most critical thing. I think that's something that the nurse and other supporting staff have as one of our biggest roles is realistically, the provider can't spend 4 hours at a visit, and can't talk to the patient about this issue again and again every week. But you can. So that's really the most important thing. Another big thing I see is that patients do what we all do, which is the doctor talks to them, they go home, and they consult with Dr. Google for a second opinion. And when they see this stuff come up, they're terrified of this long list of terrible sounding side effects. And so providing reassurance about that we are teammates together to work on this is very helpful. Now, with all of the medications, the GI symptoms is going to be your number one side effect. So in addition to going through the information about what do they eat, when they eat, make sure that they've really maximized their GERD precautions. A lot of times people may be on a PPI, for example, but really haven't done anything else to maximize their GERD precautions and can't really articulate for you what those other things would be. So that can be a biggie that's helpful. When are they taking stuff? Are they squishing doses together or inappropriately far apart? I also find that for some reason, a lot of people get confused about how to use Imodium. I've actually had patients tell me that their pharmacist told them directions that were different. And it seems to be a misunderstanding by the pharmacist that, well, if you're taking it for a side effect for medicine, you take it differently than if you're taking it because you ate bad sushi, And so people will hold it and think they're not supposed to take another one, that kind of thing. So check and make sure they have the proper understanding about how to manage the diarrhea. Appetite loss, this can be a problem because some patients want the appetite loss. They're looking to lose weight. We have to go through with them how this is not an appropriate way to lose weight. And it's also an important time when we can screen for depression, which us in the medical profession overall, no matter what role we're in, no matter where we're at, we do not do a good enough job of screening for depression, of dealing with complicated grief. So unless someone is displaying for us obviously severe symptoms relating to behavioral health, we don't deal with it. We don't bring it up. We don't talk about it. We don't find resources and treatments for this person in the same way we would if they were complaining of a heart problem or a kidney problem. Appetite loss is one of the things that is a hallmark symptom of depression. So we need to screen for that. And then chasing labs. I don't know about y'all that do this, but It's like the bane of my existence. It's the biggest time sucker. So what I do is I send out initially a written checklist that says, here's where you said you're going to get your labs done. Here's all the horrible things that had happened if you don't get your labs done. And then of course the dates or the approximate dates of what's due when. Probably the most effective thing, though, is that the providers agreed to go along with the idea of short fills, which is you get a maximum of 3 refills ever. Sometimes you're not going to get any refills. And that's much more effective when I can call the patient and say, I've gotten a refill request. It will not be filled until the day I receive your labs. And we don't like to be punitive like that. That's against a nurse's nature. But we're trying to keep them safe, and that's how it needs to happen. That's the only magic trick I have available. So let's talk about a few highlights of actually managing them. We have, now I don't want to use case study, I like patient story better, so I'm going to steal that from y'all. Casey's patient study. So she began Esbriet 9 days ago. She's stable on her other medicines, nothing new going on. She had some mild GI symptoms at first, but when she went to 2 caps, she started having bad, really bothersome symptoms. After the afternoon dose, bad nausea. And then in the evening, breakthrough GERD, reflux. Weekly check-ins with the patient are absolutely invaluable. With certain, I do it weekly with pirfenidone because of the nature of the titration. For OFEV and the immunosuppressives, that may be biweekly. So occasionally, it may even be as long as a month, but try to have initially those check-ins where we talk no matter what, not because there's something in particular to report, we're going to talk no matter what, because it's amazing the amount of information that you can take. It's also amazing the emotional effect that has on the patient. They start to really feel like they have someone who gets it, that they're connected to, and it really is important. So I get patients calling me for like completely random things that have nothing to do with IPF or ILD. It's because they're knee or they want to complain about their care provider or, different things. So when we go through with Casey in particular, of course, we're going to go through the normal thing of evaluating GI. The point really of this slide is that we can modify the titration. We can look at, she's symptoms popped up when she started 2 caps 3 times a day. So why don't we try 2 caps in the morning, 1 cap in the afternoon, 1 cap in the evening. See if she can tolerate that. Let's try that for a week and see if that brings improvement or not, after we've maximized the other things. You can, with the immunosuppressives as well, you've got some room in there to maneuver with how you're going to do the dosing. And so the key is to be flexible, figure out a plan that will work with the patient, that the patient's on board with, obviously that the provider is also on board with, but be flexible, keep an open mind. A lot of people, if they can't tolerate, they either stay forever at a non-therapeutic dose or they get off of the medicine. And that's what we're trying to avoid. With OFEV, we don't have, since it's just 1 capsule twice a day, we don't have as much room to play with, But they do have the 100 milligram dose. And for a lot of patients who can't tolerate the 150 milligram dose, and you've maximized all of the lifestyle influences that could be affecting side effects, switching to the 100 milligram dose is very effective for a lot of patients. Okay, Susan, fatigue. So Susan was tried on OFEV. She was switched over to Esbriet due to stomach pain and fatigue. We don't know if she ever tried 100 milligrams or not. What we know is she's come to us now, and she's currently holding at 222 dosing because every time she's tried to go to 3, the stomach issues would come back. But throughout this, ever since she started the OFEV, throughout this, she's been suffering with fatigue. And fatigue is one of those symptoms that doesn't appear a lot in the literature as being a primary side effect, but it's something that just in my personal experience at my center and in talking to other nurses around the country, it seems to be something they're seeing too, that a much larger percent real-world patients are seeing fatigue. For me, it seems like it's a little bit more common in Esbriet rather than OFEV. I don't really know if that's true because our center prescribes more Esbriet, so I don't know if my perception there is skewed simply because there's a larger number of those prescriptions. But it can, but I see it in both, with both drugs. So in my center, it seems to be somewhere around 25% of my patients have fatigue that's bothersome in some way. It may be bothersome, they may report it that it's bothersome, but they still are able to go about their normal daily lives, all the way up to, I literally can't get off my couch. I'm so exhausted. The most common cause for us at Vanderbilt after the GI effects seemed to be Esbriet. Seems to be fatigue. And that's true with Esbriet and with OFEV. Unfortunately, the doing the flexible titrations and dosage adjustment seems to be effective for most of the GI side effects and other side effects. But when it comes to fatigue, it doesn't seem to be as effective. Taking a drug vacation is really only effective for ruling it out as a possible contributor. But fatigue is one of the most multifactorial of all of the vague symptoms that you can think of, and as a result, they have to have a complete evaluation. It could be chronic hypoxia. They could have a cardiac issue. They could have, again, grief or depression. Fatigue is going to be a big indicator of. So all of those things need to be checked. So looking at tomorrow here on mycophenolate, she's 36. She works with the public. Husband works at the public. She's got a 3-year-old in daycare. So 3-year-olds in daycare are basically petri dishes with arms and legs, right? They're just going back and forth. So figuring out a way to come up with an infection control plan with her that'll fit in her lifestyle is going to be critical. Premenopausal females, I just mentioned that because we see so many ILD that are over the age of 50. I think sometimes it can drop off our radar screen when somebody's premenopausal. Let's not forget to keep that in mind, to give them those warnings. And not only with mycophenolate, but with the other drugs as well, make note of the potentially serious, but often vague symptoms, review that with the patient so that they will report things to you, so that they don't make assumptions and something's not missed. So for azathioprine and methotrexate, we've got people wanting to know about each. Here we've got a 76-year-old farmer and a 72-year-old retired lawyer. The point of that is just that we've got people that we're responsible for who have vastly different backgrounds and lifestyles, and that we're having to try to make all of this work for. What I tell patients is, please don't try to be the detective. Don't make any assumptions. Just any symptoms that are new or different for you, call me. We'll be the detective together. Let us figure it out together. And then I list for the patient, again, those vague symptoms that have a tendency to get lost, that people don't associate. Safety labs, methotrexate, same thing, side effect list, reassure them, let them know, because they've seen it on Dr. Google and they've made a lot of assumptions because they're reading about stuff that relates to cancer doses and not to this. So that's it. That's all my...